after inspection, we'll be doing, you know, we'll want to get you in the camera where I can demonstrate how to do your PSI, ASPs, crests, and that kind of stuff.
Okay.
But
You're back
we
on.
can do that afterward, yeah.
Okay.
Okay. So right now we're at what kind of pain is it they have, the nature of their pain, whether it's a dull, deep, deferred type of thing, whether it's constant or intermittent. Again, with the with any kind of problem in the upper or lower quarter area, is it constant or intermittent? And they very often will tell you constant, but they don't really mean constant. You say, well, I have pain all the time. Well, how about when you're sleeping in bed? No, I don't have pain in bed, but I have pain on vertebral house. Well, that's more indicative of a musculoskeletal problem. But once the pain is constant during rest, that's a bad thing. And we'll talk about that, because pain at night, there's only three things that cause constant pain at night and pain that wakes the patient up at night. One is severe inflammation, two is infection, and three is neoplasms. All three of those things are relatively bad, things that are contraindicated for active treatment. Even severe inflammation, it's very difficult to treat any kind of patient with any kind of movement therapy during the acute phase of a problem. And many times this happens in the back. They just are too acute to do anything with because the inflammation is there, and you got to let that cool down a little bit first before they're candidates for mechanical therapy. Is their problem worsening or getting better? Recently, this could be a problem they got a month ago, and then all of a sudden yesterday it came back, and you start getting into the activity at those points in time to try to determine how the onset occurs. And then the area of the worst pain, again, you want to find out where the worst pain is, because many times the pain, their leg pain is worse than their back pain, or their buttock pain. Their worst pain may be in the sacroiliac joint area, which kind of lets you start thinking about extrasegmental referral pain. All right, the pain behavior related to posture and activity. This is the very most important part of a back exam, and that is what postures cause an exacerbation or aggravation of the pain, what postures ease the pain. And we want to know whether they're sitting or rising from sitting is their worst postures. We want to know whether sitting relieves their pain or aggravates their pain. And you really need to many times get, as far as the low back is concerned, is to get into that in detail. You know, they may say, well, I can, when my back bothers me, if I sit it gets better, but then I can't sit very long, I have to get back up. That's more relevant to a disc problem. But, you know, a patient that walks a certain length of time and then has to sit to get relief, an clotting and pain behavior is more indicative of a bony entrapment problem. Functional restrictions due to pain. You can go ahead. Okay. Functional restrictions due to pain. This has to do with not being able to do normal activity, daily living because you have pain. And that can be relevant in terms of movement. People sometimes cannot sit on the toilet. They can't stand long periods to take a shower. Those kind of things are relevant to leading you in a direction of treatment. Night pain. Again, I'm just going down the list now, and you have your handout to follow right with me. The night pain is not a good thing. Now, night pain that is precipitated by movement is normal with musculoskeletal problems. Night pain that wakes people up, and it's the pain that wakes them up, not the movement from, not pain from movement. That is a red flag, yellow flag thing that you have. You don't want that happening. Patients that have night pain, you must always explore that, and if it's pain at night relative to, if the pain wakes them up and they're not moving, that's a bad thing. Again, it's one of those three bad things. Now, do they have pain on coughing, sneezing, or deep breathing? Now, this is a Valsalva phenomenon. And if you don't know what that means, Valsalva just means that you're increasing interthoracic pressure, and that's causing the pain. And in the back, it is one of a couple places in the whole body where the veins don't have any valves in them. So that anytime you have an increase from coughing or sneezing from muscular activities that surround the viscera, you get a backup of pain, a backup of blood in the veins, and if those veins are close to a neurological structure, you're going to have pain. So positive Valsalva, again, is not a good sign. It's a sign that they have pain on sneezing. Sometimes they'll have pain on forced bowel movements. Anything that causes this interthoracic pressure, and that means that something in the spine that has venous investment is getting pinched. And it's very common to see that in discs and problems of that nature. Now, other symptoms, they have paresthesias. That's numbness. Sometimes they'll come in with numbness in the foot, and you have to explore whether that is diffuse paresthesia or specific paresthesia to determine whether it's relevant to their problem. Weakness. Weakness is definitely something you have to get into in your lower quarter screen, and it will tell you where to examine in detail. And it's weakness not only from radicular issues, but also weakness you many times will have weakness in the quadriceps from a knee problem, etc., things like that. Weakness in the legs generally does not occur with things that you can treat. General leg weakness is something that occurs more with systemic problems like neuropathies and things like that we really don't get into treating as much. The last thing under other symptoms is bowel and bladder changes. Anytime you have a patient that complains of loss of control of bowel or bladder, you definitely that patient needs to go to the emergency room. Bowel and bladder, loss of control of bowel and bladder with a low back patient especially will be an indication for immediate surgery, because if you get these kind of compressions on the sacral nerve roots, they're many times irreversible, and so the patients that needs to be addressed right away. Now, bowel and bladder changes secondary to other urological problems are not what we're talking about here. Many times you'll see patients, sometimes they'll have trouble holding their bowels, sometimes they'll have trouble holding their urine, or they have urgency. Those kinds of things we're not as interested in, because those are focal problems in the urological area. What we are interested in is lack of control. You don't want to see that. Under E here you have x-rays, drugs, systemic steroids, a history of rheumatoid arthritis, and their general health. X-rays are pretty valuable really in low back problems, because they rule out a lot of problems, and we'll talk about that in the low back exam. If the patient's been on a variety of any kind of drugs, especially systemic steroids, you want to know about that, because systemic steroids in the long run do cause problems in bone and connective tissue that you just don't want to be treating in the low back or in any part of the body, really. A history of rheumatoid arthritis, you definitely want to know if there's any autoimmune problem that you're dealing with here, because these problems can invade all of the musculoskeletal system, and you have to, those are yellow flags that have to be considered in terms of any kind of treatment you're going to do. The last thing here is previous treatment and the effect of the treatment that they had. They may have already been treated with anti-inflammatories, they may have already been manipulated, they may have already seen a therapist that has done exercises with them. You want to know what's done with them and the reaction to what's done with them, so that you can better analyze what needs to be done with them as far as you're concerned. Okay, so that is your subjective history on your low back, and again, you can go along right with my worksheet. And the next thing we're going to do on the objective part of the lower quarter screen is what we want to do next, and that will involve first inspection, and we'll need to have you over here in a moment.